Hello everyone! Today we have a very exciting guest who you may already know. If you don't know her, Dr. Husain is joining us today to talk about the difference between acid and non-acid reflux. So this is a really important conversation if you struggle with acid reflux, GERD, LPR, laryngopharyngeal reflux, and Dr. Inna is a world-renowned otolaryngologist. She specializes in everything ear, nose, airway, specifically in the larynx. She's an LPR specialist. She's published lots of articles and peer-reviewed papers on the topic of LPR. I'm gonna just let her in now. And she's also trained today. Welcome everybody. Let me know where you're joining from. And let's see. Hi, and how are you?
Hi, Molly. I'm great. How are you?
I'm well. Thanks so much for joining us. I know a lot of people are really excited about this conversation, and there's lots of discussion on what is the difference between acid and non-acid reflux and what that means for medical management. So I thought it'd be helpful to just have a discussion about that together.
Yeah, happy to chat about it. I think it's a super important topic.
Yeah, awesome. I introed your background a little bit, but is there anything else you want to share with the listeners about you, your background, before we dive in?
Yeah, thank you for the wonderful introduction. I'm a board certified otolaryngologist or an ear, nose, and throat doctor, but I primarily practice what's called laryngology, so call myself like a throat doctor. LPR is definitely an area that I kind of specialize in. I take an interest in it, having suffered from it, just finding that there's not a lot of information out there, but yeah, it's a pretty common diagnosis. And so, yeah, just doing a lot of advocacy and education kind of on LPR.
Awesome. So I'd love to just dive into kind of what is the difference between acidic and non-acidic reflux?
Sure. So, when we often talk about reflux, the word acid always kind of comes with it, and that's primarily because most of the traditional symptoms of reflux have to do with like a burning or an indigestion. But we have to remember that the word reflux actually just means movement, and generally an upward movement when we're talking about the GI system. So what's moving really defines whether it's acidic or non-acidic. So generally we think of like lower pHs as being acidic. So the technical definition or cutoff is a pH of 4, and anything kind of above that would be kind of weakly acidic or non-acidic. And so when what's primarily moving upward has a pH that's above that 4, it'll be weakly or non-acidic. And so what we're talking about is essentially digestive enzymes, right? So I think it's really important to people to understand that what's refluxing, what's coming upward is actually what's in the stomach. And the stomach is not only home to acid, it's also home to digestive enzymes, which don't have to be acidic. So when what's primarily moving upward has a non-acidic component, then we call it non-acid reflux.
And is that something that you'd be finding in the pH impedance? Like, can you talk a little bit about how someone might know if their reflux is acidic or non-acidic?
Yeah, I mean, right now, unfortunately, all that's really available to us is what we call pH impedance testing to really look for that kind of the pH of what's moving upwards. Unfortunately, that's not the easiest test to get access to. Some patients, especially ones with a lot of throat sensitivity, have a hard time tolerating it, and not everyone's trained. So for most patients who receive the diagnosis of non-acid reflux, they actually don't get testing done. It's based on really clinical symptoms and presentations.
Got it. Okay. So the symptomology, can you talk a little bit about how that differs and what are some signs of maybe non-acidic reflux?
Yep. So generally we divide up symptoms based on kind of acidity in terms of traditional GERD, like heartburn, indigestion. We usually label that more as acid reflux. Now, these are big generalizations because, again, we're not really testing all those patients either. Non-acid reflux is what we think is the primary player in what we call LPR, laryngopharyngeal reflux, or the throat symptoms, right? The silent reflux symptoms, the throat clearing, the globus or lump in the throat, the chronic cough, the postnasal drip. We do think non-acid reflux is a huge huge player in those symptoms, and that we base that a lot on research that shows that using antacids such as proton pump inhibitors really doesn't help a lot of patients with those kind of silent reflux symptoms. So we have studies that show less than 40% of people really find relief from that for those type of isolated symptoms.
Mm-hmm. Yeah, that makes sense. And I hope that the pH and pedance testing, becomes more available, because I do think it can provide some valuable insights. But you're right, it's not available to a lot of people, and a lot of doctors don't perform that test, so it can be difficult.
To be frank, it's invasive, right?
It
There's a
is.
catheter in the nose and throat.
Mm-hmm.
But rest assured, a lot of research is being done into kind of figuring out more about LPR, non-acid reflux, but also kind of more diagnostic testing, meaning salivary testing, right? Like, are there kind of testing we can do on our saliva that maybe could potentially take the place of that invasive test? So there's a lot of research being done. There's exciting things, I think, on the horizon coming. So always trying to keep patients and followers to be optimistic that we are trying to find answers here.
That's really interesting. And you mentioned enzymes, and I want to talk a little bit about pepsin and how that plays a role in LPR, how that might relate to like non-acidic or acidic reflux. Like, even if you have non-acidic reflux, can that still activate pepsin?
Yeah, so pepsin is the poster child for LPR, right? So if we could just make a little mascot, it would probably be somebody wearing a hoodie that says pepsin and saying, I'm non-acid or LPR reflux. So pepsin is really fascinating. I'll be honest, like kind of geeking out a little bit here about how kind of cool pepsin is. Pepsin is a digestive enzyme that helps to break down primarily protein. It's released by what are called the gastric chief cells. Now, these are different cells than the cells in the stomach that release acid. And what happens is when it gets released, it's released as a proenzyme that the acid in the stomach then breaks down and activates into pepsin. Now, when you're having a reflux episode, it's not discriminating what's coming up, it's whatever's in the stomach. So it's likely that pepsin is in the stomach at the same time and can come up. Now, we have studies that actually show that when pepsin makes its way to the throat, it actually can be uptaken into the lining of the throat, the laryngeal epithelial cells, and it can hide out in there. So I like to call pepsin the ninja, and whenever I talk about it, I put slides with like a little ninja picture because it's hiding out in your cells. And studies have shown that it can stay there for, some studies say 24 hours. I've seen one that says 3 days, can actually hide out in your throat, waiting to be reactivated. And how does pepsin get activated? By an acidic environment. So even though the throat at baseline is not technically very acidic, pepsin can remain inactive, but not permanently inactive. So then what happens is you have an episode, and the next morning you might have a cup of coffee. Well, that coffee, which is acidic, touches the lining of the throat in which pepsin is hiding out, and it activates pepsin. And pepsin can be incredibly destructive to the lining of the throat, incredibly inflammatory, and it can cause this kind of delayed presentation of symptoms. And so it's very different than kind of how GERD kind of manifests, and why we think LPR actually can manifest with varied presentation patient to patient.
Yeah, wow. Yeah, that's really interesting. I hadn't known about the how it can really become part of the tissue and sort of inactivate versus deactivate. So, and then even if you're having reflux kind of lower down in your esophagus, like it's not coming all the way up, that can still be activated.
So it can still cause a lot of irritation, and studies have shown pepsin is a big player technically in GERD as well, which is something new that I learned recently. So even if it's a distal esophageal issue, more traditional reflux symptoms, pepsin is probably still at play.
Yeah, wow, so interesting. So yeah, I'd love to talk a little bit more about like the medical management when pepsin is playing a role, and how the medical management of acidic reflux versus non-acidic reflux might differ.
So primarily with non-acid reflux, again, talking about LPR, we like to focus a lot on things that would help reduce mechanical reflux, so the mechanical process of upward movement. Now, that can definitely be lifestyle, right? So smaller meals, bigger meals are more likely to reflux upwards, avoiding things that relax the lower esophageal sphincter. So for example, things like caffeine. And then we definitely like to use things like alginates. So alginates made of seaweed, fan favorite of using alginates for LPR because they really create that barrier, helping to reduce mechanical reflux. We both, I think, talk a lot about these more natural ways to treat reflux, and alginates, one I love is Reflux Raft, really kind of helps to reduce some of that mechanical reflux. So if you're new to kind of the world of reflux management, this probably all sounds kind of a little bit familiar with the diet, but the alginate part sounds very different because GERD traditionally, which is more traditional symptoms, is treated with primarily acid suppression. Now, I'm not going to get into a whole thing about whether that's right or wrong, and everyone's a little bit different, but we know that acid suppression won't stop mechanical reflux. I think we all kind of intuitively understand that that doesn't happen. But yes, if you're primarily non-acid, turning off acid production from the parietal cells is not going to stop pepsin from being released from the gastric cells.
Yes, exactly. And it doesn't stop that mechanical reflux exactly. So, and a lot of my clients are very surprised to learn that. And I think it's really important to know that, you know, the first line of defense for actually preventing the reflux is going to be nutrition and lifestyle strategies. So all the things we talk about on our page, and also the alginates is something that I use really frequently with my clients, especially those with LPR. I think that's so helpful to have that barrier post meal before bed, and you can kind of personalize it to when your symptoms are, if they're, you know, throughout the day or just in the evening. But I think I love Reflux Draft, and I'm so happy that you know, more people are finding out about it.
Definitely.
Yeah. Awesome. Well, this has been so helpful. I think that, you know, everyone who joined today learned something and some takeaways.
I
And
hope so.
Ina and I have lots of resources. You know, I have a ton of nutrition related resources for those struggling with LPR. Ina has a ton of information on all of your platforms related to medical management and just awareness of LPR and everything. But anything else you wanted to share with our listeners?
Yeah, I think I wanted to give a little plug for something that might be coming in the future as an anti-pepsin type of treatment. So this is actually going to give a shout out to somebody I really respect a lot in the field, Dr. Nikki Johnston from Wisconsin, who's done a lot of the basic science research for this. But the problem a lot of times with pepsin is that we are trying to address reflux, but we can't really stop pepsin directly. What's really fascinating is there's actually an HIV drug that actually has anti-pepsin properties. And so what we find in the literature is that HIV patients generally have lower incidence of LPR than the general population. And so there's a drug called fosamprenavir, and it's basically potentially could be a future anti-pepsin drug. So Dr. Johnson and her team will be starting clinical trials soon on that. So again, lots of exciting stuff happening in the world of LPR. I don't think we'll ever, you know, come away from kind of the diet and the lifestyle and trying to treat this all very naturally. But I think there are lots of different options for patients. And so stay optimistic, guys.
Yeah. Oh my gosh, thank you for bringing that up. That popped into my head and I forgot to mention it. So thank you for reminding us about that. And do you know anything about the timeline of that, like in the next few years?
No, I know they're actively starting clinical trials soon, but I don't have any more details about that.
Yeah. Well, very exciting. And thank you for all of your insights.
Yeah, of course. Thanks so much, Molly.
Awesome. So this live will be saved, and if you want to learn more about Ina, you can head to her profile. You can click down below. I'll have her linked. If you want to learn more about Reflux Wrath, that'll be linked down below. And thanks for joining, everybody.
Of course. Have a great day. Bye.
Thanks, Ina. You too. Bye.